Hello, good evening, dear friends, dear colleagues. Welcome to our ESGE webinar, Wednesday webinar. We have again today the pleasure to present papers of the month, and as usual, together with my friend Peter Siersema, I'm happy to chair this session. Professor Siersema is editor-in-chief from the Journal of Endoscopy, and we both selected, I think, two very interesting papers. This will be presented by the authors of the papers, and experts in this field will give critical comments. And I hope you can participate discussing this paper with us together. Now let's start with the first paper, a topic which is for sure very exciting, dealing with green endoscopy. As you may know, ESG has published a position statement in the field of green endoscopy, and meanwhile, many hospital centers are dealing with this topic, and I'm pleased that Harne from Pittsburgh and his group published a paper in endoscopy, and this will be after the presentation commented by Dr. Heiko Pohl. He's an international well-known expert as endoscopist and has also published many papers in the field of the green endoscopy topic. So let's start, Pratik, with your publication, and then we will have time for discussion.
Thank you so much, Helmut. Good evening, everybody. My name is Harne. I am the Advanced Endoscopy Fellow over in Pittsburgh in Pennsylvania in the United States of America. First of all, I want to thank ESG for this opportunity to present our recently published work in endoscopy, and all of you for tuning in and giving us your precious time. I'm here to talk about our prospective quality initiative titled First Step to Environmentally Sustainable Endoscopy Practice, a prospective study of minimizing multiple device use during screening colonoscopy at a large tertiary center. I have no competing disclosures. This is unfortunately a very familiar sight for those of us who perform endoscopy on a regular basis. One of the days on my endoscopy lab, this was the waste generated from half a day of therapeutic endoscopy from one room at our hospital, which is not a dissimilar site across the country. Seeing this amount of waste generated made me think about a few things. What's leading to this much waste generation in endoscopy? How are we disposing it? And what can we possibly do to reduce this waste? To my surprise, to my surprise, I found out that the burden is massive. GI endoscopy is the third most common reason for waste generation in the United States. It contributes to about 5% of greenhouse emissions, and this is unfortunately leading to a lot of greenhouse emissions, which is increasing the global temperatures. An example of this would be that there has been a 1 degree Celsius rise since 1880 to now, and now there's going to be about a 2 degree Celsius rise up to 2100, which is a rapid increase in the temperatures. Here's an estimate of the amount of waste that we are actually producing. It is projected in the United States that we're doing about 18 million annual endoscopies, which is about 38,000 metric tons of waste. Just for an understanding, this is equivalent to 117 soccer fields. Up to 1 meter of waste is how much waste we're generating in a year of endoscopy. These are the factors that are leading, and these are the major contributors that are leading to waste production with our endoscopies. Most of them are high case volumes, patient travel, decontamination process, and the use of single-use devices and non-renewable waste. For our quality intervention, we focused on the single-use devices and to see how we can reduce that. With that in mind, our mission was to reduce the use of multiple disposable instruments in colonoscopies by facilitating discussion about green endoscopy initiatives amongst gastroenterologists in a large tertiary care center in the United States. Here was our methodology. We had baseline data collected over the course of 8 weeks, we included the patients who were undergoing screening colonoscopies and excluded any other indication for colonoscopy at the time of our enrollment. We noticed number of tools that were being used for performing polypectomies in patients who are undergoing screening colonoscopies. Our intervention was discussing green endoscopy initiatives, both by the North American and the European societies in the meetings. And I'll discuss about my intervention in the next slide in a little more detail. The post-intervention data was collected over the period of 6 weeks. We again measured the same exact parameters from comparing it to the pre-intervention arm to look at the number of tools used during polypectomies, during screening colonoscopies. So focusing a little bit about our intervention. So our intervention was a passive educational intervention that focused on the impact of endoscopic waste generation. We discussed the green endoscopy initiatives set forth by the GI societies of North America and Europe. And we also discussed the evidence behind R0 resection with cold snare polypectomies during our intervention. When did we do this? We did this during our monthly meeting, as well as our monthly, which was our journal club for gastroenterologists, as well as our business meeting, which was both these meetings were held 3 days apart from each other. Our takeaway message from our intervention was minimizing the tool used during polyp resection whenever it was feasible by the endoscopist, and to review best practice guidelines. Here were our results. This is a results table showing our pre-intervention and post-intervention arms, which is just comparing the demographics and some basic data. This table showed us that the age, male to female ratio, and polyps per colonoscopy were pretty similar to the pre-intervention and the post-intervention arm, telling us that both these arms were fairly comparable. In terms of our results, we had 210 patients in our pre-intervention arm on the left side of the screen. 34% of these patients required no intervention during their colonoscopies. 32% required only one tool for performing polypectomy. 33% required multiple tools during polypectomy. On the right side in the green, you see our post-intervention arm, which was after our intervention. So it included 112 colonoscopies. Again, 34% required no intervention. But what we saw was 49% of them required only one tool to perform polypectomies, whereas only 17% required multiple tools to perform polypectomies. Interestingly, after our intervention, our gastroenterologists were 3 times more likely to use less tools during polypectomies, which was statistically significant and indicated by the odds ratio of 2.98. This is a bar graph depicting the use of tools before and after our intervention for screening colonoscopies, before shown in blue, after shown in green. So you can see that the use of snare and biopsy forceps alone increased. However, the use of multiple tools for performing polypectomy went down. I would also like to mention that use of snare and multiple tools usage were both statistically significant. The strengths of our study were that it was easily reproducible. We had tangible, objectively measurable goals and results. It was very low cost to actually implement the study. And there was no Hawthorne effect telling us the gastroenterologists were completely blinded that they were even included in the study. The limitations of the study were that it was a single center study, the sample size was relatively small, and the assessment was shorter. To conclude, we concluded that there was a significant change in practice patterns favoring the use of single instruments over multiple instruments for polypectomies during screening colonoscopies after a low-cost, environmentally conscious intervention of open-ended discussion regarding green endoscopy initiatives. This project made me think about Sir Isaac Newton. He made 2 different sized cat holes for 2 different sized cats in his house. But what he saw was both his cats were using the bigger hole to go out in and out of his door. Maybe we can do the same with polypectomies and use only the tools that we need. Thank you.
Thank you, Pratik, for your presentation. And now I'm curious what Heiko Pohl has on comments for this paper. And after that, our participants can use the Q&A button for their questions. So Heike, what do you think about this paper?
It's a great paper, Pratik. Thank you very much for, I think, doing the work and measuring what you've been doing before and after. I think there are some interesting points about this. In general, I hope that others feel inspired to do something similar in their unit and see what their intervention affords in terms of benefits. So I'm curious. So my understanding is that you had the endoscopists being blinded before and after, so they never really knew that they were measured. So in other words, you had an intervention, and the subjects of being studied, they were blinded. So did you unblind them, and how did they respond? And do you think that was a more lasting change in their whatever they do?
Yes, thank you for that question. We did unblind them at our next business meeting and told them when we presented our paper and our findings. They were very surprised, first of all, that we were using their data to monitor this, but they were very happy and relieved that we were able to actually make an impact. Around this time when we were doing the study, we also reviewed the ESGE guidelines that came out this April, which showed which recommended that we use cold snare polypectomies for even diminutive polyps. And we understand that some endoscopists did prefer at times to use biopsy forceps to actually remove a polyp. But then after reviewing these guidelines and our study at our own center, they were more open to just using one tool, and that was just a cold snare, take out the polyp whenever it was feasible, and they were very open to change. What we are hoping to see now is how it lasts in terms of a long-term effect and how it translates into a long-term study, and also to look at R0 resection in terms of resection margins being clear and there is no recurrence in follow-up colonoscopies.
Yeah, I think the idea of following or documenting the number of instruments that are being used by endoscopists as somewhat of a quality or assessment is interesting without being accusatory or blaming someone. What I also found interesting, that I think the calculation is right, that 88% of endoscopists before the intervention used a forceps for polyps. So all the 88% of polyps were removed by forceps. And after the intervention, 78% were still removed by forceps, which tells me that at least in your practice, the guidelines, US or ASGE or ESGE, have not been really embraced. And you were just mentioning that. So that's kind of an interesting situation. Do you want to comment on that?
Yeah, absolutely. I think the way I have been trained in the recent times is try to go for the cold snare whenever you can. I think we're slowly seeing this shift away from the forceps to remove a polyp, only because more and more data is coming out about incomplete resection. There were a mix of gastroenterologists in this cohort. They were young, and there were a bunch of old gastroenterologists as well. So there was a lot of different opinions. But when we saw the data and we saw that cold snare polypectomies leads to more complete resection, we're okay in removing 1 to 2 millimeter of margins with it. There's nothing wrong with it. So instilling these changes, I think our group as a whole became more open, not only in their own practice, but also when they're training their fellows, that it's okay to go ahead with the cold snare for that small polyp, and it's okay to get a little bit of a margin. That's completely within the new practice now, which was very refreshing to see after the paper, at least at our center.
Yeah. Maybe one last question for me, and then others can also chime in. What do you think is the biggest benefit of this kind of environmental green practice change in terms of towards a sustainable endoscopy practice?
I understand, the way I see this is that during my research, I found out that there's a lot of factors that are contributing to the GI waste. And this is maybe a very small fraction of the whole pie. So this is something that the endoscopist at their own center, with low cost, with self-discipline and self-education can implement. There are certain things that I feel that can be done at the individual level, then at the systems level, then maybe at the society level, and that's how it can kind of can translate. But even if we can start somewhere, I feel that can have certain impact on saving the environment as a whole, because the amount of waste that we are generating right now truly it's abysmal.
Yeah, I think I'm hearing often the question of, you know, okay, now we're using a few less snares or forceps. What's the benefit? You're not saving the world with that, and you know the benefit in terms of lowering carbon footprint is probably also very low when viewing the entire colonoscopy, and even the amount of waste that we save is low. I think in general, but what seems like what your group has shown, it's actually a change in culture, and with a change in culture, you might inspire, or that might be followed by other changes in general how to practice. And I think that's a very important point. Not that we have a major decline in carbon footprint, which I hope we will have, but also that we just have a different approach to it and have the awareness to it and have a change in culture. Right. Any other questions?
Yeah, there are two questions.
I have a question as well.
Two questions chat over.
I have a question as well, Helmut, if you allow me. You mentioned that already, but what do you expect on the long term? How will endoscopists behave on the long term in reducing the number of devices they use for colonoscopy?
Yes, I mean, I think that's something that we are hoping to strive for, either in terms of more reminders or more quality data coming out of the institution first, and then multi-centers and societies as a whole. I would say it really helps when societal guidelines come out saying that you can just use this one tool to remove diminutive polyps. That really does help guide the endoscopists to use just one tool over multiple. Apart from the environment, which is I feel the most important and burning need, there's also the cost implications. A lot of places in the US do have to pay more money to use more tools. So if you don't necessarily need those, we should not have the patient incur such bills and stuff like that. So sustainability and the practice being a long-term effect change still needs to be seen. I feel there needs to be a longitudinal study based off of our index study to see if there was any long-term change that we made where people are using lesser tools to remove their polyps, or gone back to square one, hopefully not, to use multiple tools to remove polyps.
So do you think that you need more interventions on the long term, so that you need to repeat the intervention that you initially did?
I think so. I think there needs to be a longer term study where maybe if we do it in the same group, or just a study that runs longer over the course of 6 months to a year, to understand the behavioral practices of fellows, and gastroenterologists, community gastroenterologists, to see in a specific practice, to see how they behave after reviewing some guidelines with them on a regular basis, to really see a long-lasting change in their practice pattern.
I see. We have some questions from the audience.
Yeah, two questions. One question is, what other points do you see for making endoscopies more green besides polybectomy?
Sure. So like I mentioned, major contributors are large volume of cases and patient transport. So there was a lot of carbon emission in these specific areas. So volume of cases, we can always regulate, try to see and perform endoscopies only in the patients who truly need them, rather than ordering incessant amount of endoscopies with softer indications, which will also lessen the amount of patient travel back and forth, because somebody has to drive the patient to the endoscopy center. Sometimes they go back home and they travel back. So there's a whole lot of carbon footprint that is contributed outside the endoscopy lab just by doing your endoscopy. And the other thing would be just combining procedures that need to be done together instead of, say, for example, a patient needs an upper and a lower endoscopy, maybe doing them on the same day instead of scheduling them on 2 different days. Would be another way of reducing the number of times you're doing everything all over again. Other points can also be disposable versus non-disposable instrument use. We're seeing that disposable instruments do generate a little more waste. So selecting them, like being very selective about using them and their indications is very important, so that we do not contribute to more waste being generated during our endoscopy practices. And also the other big part that I also saw was the amount of pathology samples we sent out to pathology. So if you truly don't need 7 pathology cups to be sent down to pathology, and you can make it do with 2 or 3 and just enough have that same information, then maybe we should try for that, because then that way we'll be doing a huge favor to the environment and our future generations.
You already answered a part of the next question, and this was also my concern. Should we stop removing diminutive or very small polyps, especially in elder patients? So that means becoming greener and greener. Do we lose quality?
Yeah,
Go ahead, Dr. Siersema, you were saying.
no, I said that's an important issue, of course. So are we going to lose quality when we become greener? And that's and worry, of course, of many people.
Absolutely, and that's a very valid point. I think we now have enough data to understand which one of these diminutive polyps on visual diagnosis can confidently tell us that they're benign and versus pre-malignant. We understand that if there is doubt, you can always go for resection. But if you're seeing a polyp which is 4 millimeter, hyperplastic appearing below the sigmoid colon, you know probably that this is going to be a hyperplastic, non-malignant transforming polyp. And you might be safe in just leaving these alone rather than chasing them. So optical diagnosis really plays a big part in this entire scheme of things. So using those, looking at the pit pattern, looking at it with advanced images while you're performing your endoscopies is always a great tool at your disposal that comes at absolutely no cost. So that's something that you should consider in your daily practice.
Okay, thank you. Pratik.
Comment on this?
Yeah.
I think it's a great question. The quality question, Peter, that you're asking. I think on the flip side, though, thinking sustainably, or at least having the green thing in mind, questions perhaps our practices. And do we really need like a biopsy and a snare? Should we really remove that polyp? Is it because it's hyperplastic polyp, like the leave resect and discard and leave approach? I'm not saying that we need to jump there, but it might open up our perspective of questioning some of our ingrained ways of doing endoscopies, and maybe there's room for reducing what is really not essential, or understanding better what is essential to also maintain quality. So I do support the idea of resect and discard. I think there's some groups looking at cost effectiveness plus environmental analysis on that, and there's probably going to be a benefit in this. So.
Okay, thank you. So, I mean, one last comment from my side. Pratik, you already mentioned transport costs from patients, or the footprint of CO2 for transportation of patients is quite high, even in Germany. 40% belongs to this issue. And now our healthcare minister recommends centralization. So we should send patients to specialized centers, which increases for sure the way to go to a longer distance to centers. So on the one side, specialization, higher quality. On the other side, the CO2 footprint will increase. This is my opinion in Germany. I'm not sure how it will be in the US. What is the policy in US? Heiko and Pratik, short comment.
Yeah, so in the US, it's not a centralized system thus far. I hope we don't follow suit, because we love to follow you guys in a lot of things. But we do have smaller centers in smaller communities where basic procedures can be performed, and typically
Yeah.
if they fail or the indication is something that they
Well, I'm not
cannot
talking about basic procedures as a specialization, for example, ESD or POEM procedures. This is all, yeah.
Yeah, that remains similar. That only
Yeah.
happens at
Yeah.
usually bigger tertiary care centers, and that would unfortunately, yes, add to the cost, but
This will
that kind of
increase
care is
here
able
too.
to go on. Yeah.
Okay, so thank you guys. I know you were both busy. It's lunchtime in the US, so thank you for taking the time to present the paper, to comment the paper, Heiko. It was great to have you both here. I wish you both a nice Christmas. Enjoy the next couple of days before we start in 2025 with a lot of energy.
Thank you very much.
Bye-bye.
Well,
Thank you.
Thank you so much for having me.
Thank you.
Okay, Peter, now it's your turn to introduce the next paper.
Yeah, we go to the next paper, and the next paper will be presented by Dr. Onnekink. She's going to share her screen. It's a paper about sphincterotomy to prevent post-ERCP pancreatitis, and she asked herself the question whether we should use a self-expandable metal stent. And this was a large study with a lot of people that were involved, mainly from the Netherlands. And it will be interesting to hear the result of this SPHINX trial. And afterwards, the paper will be commented by Dr. George Webster from London.
Yeah, well, thank you for the introduction. I'm Onnekink, a PhD candidate at the gastroenterology department at the Leiden University Medical Center. And we're happy to present the results of the SPHINX trial in this webinar today. And for a discussion, Roy van Wanrooij from the Amsterdam UMC will also join us. In the SPHINX trial, we investigated whether endoscopic sphincterotomy can prevent post-ERCP pancreatitis after fully covered metal stent placement in patients with distal malignant biliary obstruction. And now we present the results of our multicentre randomised controlled trial. I have no conflicts of interest. Most of the patients with distal malignant biliary obstruction suffer from pancreatic head cancer, approximately 75% of the patients, followed by distal cholangiocarcinoma in approximately 10% of the patients. And these individuals can suffer from symptoms such as jaundice, cholestasis, or cholangitis, and therefore require biliary drainage to alleviate their symptoms. And this may also improve their quality of life, or could also be needed prior to the start of neoadjuvant treatment in case of a resectable tumor to normalize bilirubin levels. The standard of care for biliary drainage is ERCP with placement of the stent. And metal stents are the preferred stent types. And they are preferred over plastic stents because they lead to fewer overall complications and they have a longer stent patency. However, we know that in this specific patient population, that after the introduction of metal stents, the rates of pancreatitis increased up to 18%. And that's also something that you can imagine when looking at the image on the right, because you see that the metal stent is well capable of opening the bile duct. But the fully covered stent blocks the orifice of the pancreatic duct. So pancreatic juices cannot flow out anymore, which may increase the risk of pancreatitis. And a potential solution to this is the use of endoscopic sphincterotomy. And this is already performed by many endoscopists, also to facilitate biliary cannulation or and stent placement. But it may also reduce the risk of pancreatitis by decreasing pancreatic sphincter compression by making a small cut in the papilla. Thereby pancreatic juices may flow out again and the risk of pancreatitis may be reduced. So the hypothesis was that endoscopic sphincterotomy can reduce the risk of post-ERCP pancreatitis after fully covered stent placements in patients with distal malignant biliary obstruction. And this hypothesis was tested in the randomized SPHINX trial. This was a multi-center superiority or randomized controlled trial in which we tested whether endoscopic sphincterotomy was superior to no sphincterotomy in the prevention of post-ERCP pancreatitis. In the study, 17 hospitals participated, including 16 Dutch centers and 1 Spanish hospital, and we started back in May 2016. Patients with suspicious distal malignant biliary obstruction were able to participate, and patients with a more proximal stricture, so those with stricture close to the liver hilum, could not participate, as well as those who received prior precut sphincterotomy or with a prior PD stent in the pancreatic ducts. Eligible patients were randomized in a 1-to-1 ratio to the sphincterotomy group, so this is the intervention group, or to the control group without sphincterotomy. And this is also visualized in the images below. So in A, you can see the ERCP, and after successful biliary cannulation, sphincterotomy is being performed. And then in B, a fully covered stent is being placed. And in the control group, there was ERCP with biliary cannulation, without sphincterotomy, and then also a fully covered metal stent was placed. And this was a Cook evolution stent with a diameter of 1 centimeter. Patients were followed up 7 days after the procedure. This was to assess the short-term outcomes. And the end of follow-up was at day 30. And this also marked the end of the study for participants. The primary outcome was the occurrence of post-ERCP pancreatitis within 30 days. And secondary outcomes were other complications, such as bleeding, perforation, colonchitis, or cholecystitis. And we also assessed the 30-day mortality. So in total, 297 patients were randomized, with 156 patients in the sphincterotomy group, so the intervention group, and 141 patients in the control group. And it was quite striking that more than 500 patients were screened for eligibility, of whom 177 patients could not be randomized during the ERCP. So they were eligible to participate, but there was no successful biliary cannulation, or they needed a required sphincterotomy, or a prophylactic pancreatic duct stent. So when we look at the baseline characteristics, these were similar between the intervention group and the control group. A bit more than half of the patients were male. Median age was approximately 70 years old. They were still quite fit at the time of the procedure, and bilirubin levels were higher than 200, and the main etiologies were pancreatic cancer with more than 70% of the patients, followed by cholangiocarcinoma in approximately 15% of the patients. Some ERCP characteristics. The median attempts for cannulations were 3 and 2. And even though all patients had a successful biliary cannulation, still 1/3 of the procedures were considered to be difficult, meaning that it took more than 5 attempts to cannulate, or more than 5 minutes, in according with the ESGE guidelines. And also 1/3 of the patients had an incidental PD cannulation. Well, then we're at the point of our primary outcome, and we found that 26 patients in the sphincterotomy group, so 17% developed pancreatitis, and 21% of the patients in the control group, meaning that there was no difference between the groups. And this was also found at our interim analysis after 50% of the patients were included. This lack of difference also meant that our trial was terminated prematurely on the basis of fertility, because there was no difference in post-ERCP pancreatitis incidence between the groups. When we look at the severity grades, according to the revised Atlanta criteria, we see that more than 80% of the pancreatitis cases were mild, luckily. And regarding the secondary outcomes, the incidence of bleeding and perforation were really low. And stent-related morbidity with colonchitis and cholecystitis were also similar between the intervention and control group, as well as the 30-day mortality. And almost all cases of mortality were unrelated to the procedure and more to progressive disease. We also checked whether there was a benefit or a lack of benefit of sphincterotomy in several subgroups, including age, sex, but also whether those with a dilated by PD or with a difficult biliary cannulation, or whether they had a incidental pancreatic duct cannulation or contrast injections. And we found no benefit in any subgroup, meaning that there was no significant treatment effect in all the subgroups that we tested. So yeah, that brings us to the conclusion that there was no difference in post-ERCP pancreatitis between the endoscopic sphincterotomy and the control group. There was also no increased risk of other complications after sphincterotomy. And endoscopic sphincterotomy was not proven superior to prevent pancreatitis in this setting. So yeah, in absence of a clear benefit, there was insufficient evidence to recommend routine sphincterotomy prior to fully covered metal stent placement in patients with distal malignant biliary obstruction. And well, thank you, and we're happy to take any questions.
So, well, thank you very much for your very well-performed presentation. And of course, it will be nice now to hear the opinion of George Webster, a well-known ERCPist from the UK. And I think it's one of the persons that really knows what he talks about when he speaks about ESGE. George, the floor is you.
Thanks very much, Peter. My first thing to say is Anchor and team, great study. As usual, great study coming out of the Netherlands. Thing I like about this is that it's clinically relevant and it's addressing a question that we are presented with almost every day doing an ERCP. So I think it's a really good study addressing the question that we always have, within our groups as to whether we should be doing a sphincterotomy before putting in a fully covered metal stent. A few things I wanted to bring out, really just as points of discussion. I thought we'd start with the methodology and Anchor, as you pointed out, there were over 500 patients who were screened as being eligible, but there was a significant dropout at randomization stage. What is that? About 40% of patients did not reach randomization. Now, I think there's a really interesting observation. You've mentioned this, but in 9% of cases, it was not possible to cannulate the bile duct at all. In 94 patients, it was still not possible unless one reverted to a pre-cut sphincterotomy. And that's looking at this data, and obviously I don't have the fine detail, but at least 28% of patients failed conventional cannulation. In other words, no pancreatic stenting, no pre-cut, just wire-guided biliary cannulation. That says to me that, which is what we know, biliary cannulation is damn difficult. And it's one of the most challenging things in ERCP. And before we get into all the technicality of clever stenting, cholangioscopy, and all this sort of stuff, I think we need to recognize that for trainees and for practitioners, the most challenging thing about ERCP is cannulating the bile duct. The next thing I wanted to bring out, which I think could have a relevance to the results, is that in your inclusion criteria, putting in a pancreatic stent precluded randomization. And so, and yet we know in your data that in 30% of cases, there was pancreatic wire-guided pancreatic or contrast filling of the pancreatic duct. And yet, in only a minority was a pancreatic stent put in, and all of the patients who were randomized who had pancreatic duct filling, none of those had a pancreatic stent, because if they did, they were excluded from randomization. And as we move on to the pancreatitis rate, I just wonder if that might be playing a little bit of a role. And maybe I'm just introducing a couple of papers that might inform the discussion a bit. And one is this paper from Joseph Almunza in the Lancet earlier this year, in which they randomized patients to either indomethacin or indomethacin plus a pancreatic stent. And their conclusion, certainly for high-risk patients, was that pancreatic stenting did provide a benefit in reducing the risk of ERCP pancreatitis. So maybe that inputs a little bit in some of the data that you've found here. Couple of other things about inclusion criteria, a bit less important. We are presuming that the patients had malignancy, but we don't have evidence of that. And something that maybe we get on and discuss at the end is there's no mention as to whether brush cytology was done during the procedure. And I would feel that doing brush cytology without a sphincterotomy is an awful lot more challenging than with a sphincterotomy. So that's something to think about. The other question is the degree of biliary obstruction. Less than 70% of patients had any, was said to have cholestasis, and less than 25%, or rather more than 25% had clinical jaundice. When we look at the bilirubin, the mean bilirubin was more than 200. And so I'm going to pose the question, was an ERCP necessary in all these patients? Clearly, it wasn't included in the inclusion criteria, as an exclusion rather. But if we look right back 15 years ago now at the Dutch New England Journal paper, in which compared early surgery with ERCP and stenting, a conclusion of that study, and we can argue about the conclusions, but a conclusion was that in patients with a bilirubin of less than 250, ERCP and stenting wasn't mandated, and that if the patient could get to early surgery, that may be to their benefit. Now, I know that in the UK, and it may be the same in the Netherlands, in practice, it's pretty difficult getting a patient who is jaundiced to a Whipple's resection without any biliary intervention. But maybe that's something for us just to think about as to whether, in retrospect, all of these patients needed an ERCP. Because then when we come on to the results, they're interesting. And as you've said, the rate of pancreatitis is no difference in those patients having a sphincterotomy with not having a sphincterotomy, but the rates are pretty high of pancreatitis. And one of the curious things, and I know you point this out in your discussion, is that the previous study, similar to this, way back in 2008 by Artifon, they showed no cases. There were 74 patients, and they showed no pancreatitis in either the sphincterotomy or the no sphincterotomy group, which was extremely surprising. And the other thing in your study, of course, is that 2 of the patients died of post-ERCP pancreatitis. And when one steps back and looks at that, that means that 1 in 150 patients having their ERCP died of pancreatitis. And I just wonder, certainly in the UK now, we are discussing that, and we're discussing the risk of death in our consenting for ERCP. And I'd be interested to know what the view is of that, because actually the patients in this study were what we would call essentially in a low risk group for pancreatitis. Many of them had a dilated bile duct. Many of them were elderly. They had high bilirubins. 12 of them had had a previous stent. So, you know, although some of the ERCPs were said to be difficult, overall, cannulation was not thought to be difficult. And yet we're still getting a high pancreatitis rate. Now, that may be due to excellent recording. We know that in studies that, you know, if there's very good, strict follow-up within studies, that we always find a higher pancreatitis rate. And maybe this represents real practice. But if it does represent real practice, then does this then pose the question, again, should we be doing ERCP for patients with biliary obstruction? And what do I mean by that? Well, again, just to briefly mention, been a couple of studies on this, and I'm sure, Anke, you and your team have been thinking about this, but the paper end of last year comparing endoscopic ultrasound guided choledocho duodenal stents versus ERCP. And in that study, 73 patients receiving EUS, there was no pancreatitis in the EUS group. And there were a few cases of pancreatitis in the ERCP group. So, you know, I think this is an emerging point that we need to all be considering. And so I suppose my final questions to knock around are quite a high rate of pancreatitis in both groups.
Well, George, maybe we can do them one by one. So we start with the first one, and then we go down and take all the questions. So Anke, and maybe also Roy. The first question is high PEP in both groups with 150 patients dying. Is there an explanation for that?
Yeah, well, we saw that only 2 patients in this whole group, so 2 of the almost 300 patients developed eventually had a very severe course of pancreatitis. So one of them died with multiple organ failure, and one due to pulmonary failure and pneumonitis. Yeah, well, I think also in other pancreatitis studies, we know that there's also a small percentage of patients with pancreatitis due to after ERCP. So I think that's not something really new. Yeah, and considering the high rate, I do agree that that we initially thought that it was not a very high risk patient group. So we also expected the overall incidence to be lower. But then again, it turned out that this actually was quite a difficult patient group, or it was difficult to perform the ERCP procedure because we already do have a selection of patients in which the biliary cannulation was successful because, like already stated, almost 40% of the patients were excluded because it was not even possible to have a successful biliary cannulation without pre-cut sphincterotomy or a PD stent. And yet there's still this high rate. And I think it does have to do with our meticulous follow-up because for every little pain, we ask patients to contact us, and we measured their amylase and lipase levels in the blood. But
I think
yeah.
I think that's very likely to be a big factor in this.
Yeah.
But also, I think that, you know, in terms of training in ERCP, many, you know, we've seen here that primary cannulation without either a pre-cut sphincterotomy or the placement of a pancreatic stent, you know, can make it a real challenge, you know, and yet things like pre-cut sphincterotomy, many fellows finish their training having done almost no pre-cut sphincterotomy.
Yeah.
And there is some data, debated, but there is some data showing that the early use of pre-cut sphincterotomy can aid biliary access and reduce ERCP pancreatitis. Now, clearly, there's every reason why a pre-cut sphincterotomy here resulted in the patients not being able to be randomized for obvious reasons. But in terms of outcome, you know, it'd be quite interesting to know, which is my second question, whether you have any information on the outcome and the pancreatitis rate in those patients, for example, who did achieve biliary cannulation, but with a pancreatic stent or with a pre-cut sphincterotomy. It may be a simple answer that no, you don't have any of that data, but I just wondered if you did.
Yeah, no, it's a great question. And yes, you already gave the answer. Unfortunately, we don't have the data because like intercystin patients were excluded right away. And then there was not even opportunity to fill out all or to fill in all measurements. But of course, we still have the patient ID. So it is actually still a question that we still have. Like, could we maybe in the future, if there's time, to look for the to check all complications in the patients that were excluded, because that would also provide some valuable insights. Yes.
Okay. And my final question, and then others may well have other ones, is I can't decide on the basis of your study if we should or we shouldn't do a sphincterotomy. What
Yeah.
do you know? It's easy to say, oh well, the evidence suggests that there's no reason to do a sphincterotomy, but very surprisingly, the only patients, for example, who had bleeding or had a perforation in your study were those who did not have a sphincterotomy.
Correct.
And so an argument that, oh, well, we must not do a sphincterotomy because it presents risk is not borne out by your study.
No, that's correct. Yeah.
We can argue that it doesn't, you can argue that it doesn't provide a protective effect, but it doesn't, on the other hand, suggest that it's a risky thing to be done. Do you have a, or maybe within your unit, have you changed practice? Do you know? And maybe Roy could answer this, or have you changed practice on the basis of the SPHINX study?
Yeah, maybe Roy.
Yeah, we actually did stop doing it routinely, but as you saw in the data, we have quite oftenly we perform a pre-cut sphincterotomy just to facilitate the biliary cannulation, because potentially in a study, because you know that you cannot randomize the patient, you try a little bit longer with cannulating. And you all know my former boss, Paul Fokkens, he took already the needle knife after 12 seconds.
Yeah.
Because he feels comfortable with the needle knife. So, and that's a very interesting topic, especially when you do a fistulotomy. So yes, routinely we did stop doing the sphincterotomy also because what does it add? Yeah.
Okay, so, and do you think there's any chance that some patients were hesitated to put in a pancreatic stent because of the awareness, understandably, that would then preclude randomization?
Yeah, I think that is the most crucial part of the study that probably explains for the high PEP rate. So you know that you will exclude the patient from randomization, but you also have to realize that the study has been performed over a 7-year time frame. And if you think back of the practice 7 years ago, pancreatic stents were not as popular as they are now, right? It was considered to be a little bit annoying when you place a stent. It's more difficult to cannulate over the stent. And you had the guidelines saying you could have one PD cannulation, and only the second time you cannulated the PD, you needed to put a stent. And now with also changing practice and the new data that we have, I think we put the PD stent much sooner and also get easier with it in practice. So I do think that's also what you see in this study over 7 years.
So, George, what is your practice based on this study?
Yeah, my practice is very often to do a sphincterotomy. To be honest, I think that doing other forms of intraductal tissue acquisition is tricky without a sphincterotomy. So I think that I noticed in this study that a little bit under 30% of patients had an EUS for tissue acquisition, I think as part of the same procedure. I think I'm correct in saying that.
Yeah, that's correct.
But if you don't do an EUS, your only other means of making a tissue diagnosis is obviously intraductal. And I think that whatever the debates are about the need for a sphincterotomy, I think it's pretty difficult to do brush cytology without a sphincterotomy. It may increase the risk, and certainly other procedures such as cholangioscopy you can't really do without a sphincterotomy. I think it's a very, I would just say that the thing that I very much like about this study, it did take a long time to recruit, but I think that the studies from the Dutch groups provide real, believable results in the sense that they're not just from a single super specialist center. I think these results are transferable to practice, in a broader, across a much broader spectrum of, of endoscopic practice. So I think that, it's an important question. It doesn't, I don't think, allow us to say you must never do a sphincterotomy or you must always do a sphincterotomy. I think the results on pancreatitis are interesting, and I think that I don't think we trivialize pancreatitis, but you can see from this data that pancreatitis, particularly for patients who might be going on for surgery, can be a disaster because it can completely preclude a potentially curative Whipple's. And we would still do an ERCP for a patient with malignant distal bile duct obstruction. But I think that over the next 10 or 15 years, maybe and maybe less than that, our practice might change if EUS approaches demonstrate a much lower complication risk than we get with ERCP. But this is very nice work.
Well, I think that you're absolutely right. It's a very important study for the daily clinical practice. My question is actually, would the study have been different if you had used another type of stent, or maybe if you had used a plastic stent instead of a metal stent?
Yeah, that's a good question. I think maybe Roy can tell something more about other metal stents, because I'm not very an expert on all the different stents you can use. But I think that the period of plastic stents, especially when you don't know how long a stent will be inside to before surgery or in a palliative setting. So I think, yes, if you would have used plastic stents or multiple plastic stents, the risk of pancreatitis would have been lower. But I still do think that it's not preferred, because the risk of other complications is higher. And we do know that plastic stents perform evenly well or better when you perform surgery in, let's say in 2 weeks or so. But then again, you could also maybe argue why you should even perform ERCP with stent placement if you can already perform surgery within a short time period, because that's also what the previous Dutch study showed, that you can just continue for surgery without ERCP.
So Roy, do you have an opinion on the type of stent that you've used?
You mean covered versus uncovered, for instance, or different brands?
Evolution versus another type of stent. You use the Cook stent, but there are of course also other fully covered stents that could have been used.
Yeah, there is some difference in radial forcers. I don't know them by heart. So you could argue that if you have a stent with a high radial force, the chance of pancreatitis is higher. But you could also say that if you perform a sphincterotomy, you actually alleviate that risk. So
I don't know that there's any evidence to suggest that choosing a different stent would have made any difference here. We know that effective biliary drainage is worse with plastic stents than it is with metal stents. That's one of the criticisms of the original surgery versus stenting study. Do we know that this has got anything to do with having a stent in? This could just as easily be the manipulation of the sphincter and doing an ERCP. We know that is the overwhelming risk of ERCP pancreatitis, is simply manipulating, instrumenting the papilla. So, I think it gets back to that question: is should we be instrumenting the papilla rather than, any stent design would be my feeling. But
no, I totally agree with you, because I was also looking at our data, and you see, even though we don't have the power to make a substantial conclusion about that, but we see that the incidence of pancreatitis is higher among those with incidental PD cannulation or contrast injection, then it's above 20%, or even reaching 24 to 26%, where this is definitely lower in those without PD cannulation or contrast injection. So I think that's definitely a factor that has influenced the pancreatitis incidence in our study.
Well, indeed, and I think we have to conclude this session because it's 2 minutes behind 8, and I think I would like to thank you for this fantastic discussion. I think very insightful and also important for the audience. We have also some questions from the audience, but unfortunately no time to answer them. On the other hand, some of these questions have been discussed more or less also during the last 15 minutes. So thank you very much for participating and for the discussion. And we have some final slides to conclude. Don't forget that there is ESGE Days the next year in 2025 from April 3 to 5 in Barcelona in Spain. So please join us there in Barcelona. And that's of course always a pleasure to see all endoscopy friends all together. I think we have some more slides. Also important, if you have an innovation or if you think there is an innovation that's important, you can nominate this innovation for the innovation of the ESGE award, of the year award. That is also up to the 21st of January, and it will be awarded during the ESGE Days. The ESGE Academy, also important, how you can train and learn about endoscopy can be learned in the ESGE Academy. And then I think final slide is about the young phases of endoscopy. Endoscopy is depending on young phases, and please join us, please join the ESGE, and well, I think that's fantastic. Next week we have the last webinar of the year, Wednesday, December 8th, and it is a Jubilee webinar, as you can see. And the title is ESGE as 60 years, pioneering the future of GI endoscopy. And of course, you're welcome. And thank you also to David and Vaso. And I wish you a Merry Christmas and a Happy New Year.